Hello, my name is Kelly Gwathmey. I'm a neuromuscular neurologist at Virginia Commonwealth University in Richmond, Virginia. And it is an honor to welcome you to this podcast called Understanding Generalized Myasthenia Gravis, gMG. And this episode will be focusing on the latest advances in gMG therapies and guidance for implementation into clinical practice, also with a focus on treatment of pediatric myasthenia gravis. And with me today, I have Dr. Sithara Ramdas. She's a consultant pediatric neurologist at Oxford Children's Hospital in the UK. Welcome, Sithara.
Thank you, Kelly. It's a pleasure to be here.
And so, we will jump right into it. We'll be going through first the epidemiology and risk factors of myasthenia gravis, both in adults and children. And so, on the adult side, GMG, the prevalence is about 150 to 200 per million. And as a lot of our learners know, there's a bimodal peak in adulthood. So, we have a concentration of cases around that peaks around age 30 that tends to be more common in young women, and then after the age of 50, there's a second peak where men and women are more evenly matched in terms of the prevalence. And so, Satar, can you tell us a little bit about how it presents in children?
Absolutely. So we've got slight differences in children. So first of all, just the definition. So when you talk about juvenile myasthenia gravis, it's onset before the age of 18 years. And then what we do is we do subclassify them into prepubertal and postpubertal, and puberty generally is taken between 10 to 12 years. Okay. So what we see with the postpubertal is, like you mentioned, Kelly, it's like a young adult female population, similar characteristics. But our prepubertal patients are slightly different. In particular, the sex incidence tends to be similar or maybe only slight female predominance. We tend to have much more ocular MG and they stay isolated ocular. The rates of generalization are much lower. And what we also see is quite high rates of seronegativity, and that's quite important from a diagnostic point of view if the antibodies are negative. And particularly from an ethnicity point of view, we see in our Chinese ethnicity and the Black African ethnicity much higher rates in the prepubertal population. When we look at incidence globally for JMG, there is again a clear ethnicity difference. So, in studies with predominant white Caucasian population, it varies between 1 to 2.5 per million. Whereas if you go to the Chinese population, it really can be up to 4 to 8 per million. And similarly, in the Black population, about 4 to 4.5. So you have this ethnic difference within JMG, which is not really seen in the adult MG.
That's extremely helpful. And I think you've already touched very nicely on the different clinical presentations in pediatric myasthenia gravis, including the higher prevalence of ocular manifestations in the younger children. In contrast to the adults, where we have, the majority of our patients, 80% or so, 75 to 80% will be generalized at some point, with a minority having ocular only symptoms. It does seem to be a little bit different, and of course, we have a higher percentage of patients that are seropositive. I'm just curious, can you speak to the kind of the antibody distribution in the pediatric population? For example, do you see children with musk antibodies ever?
Yeah, so with regards to positivity, so AChR and MuSK are the two antibodies that we see. So similar to adults, AChR is the common antibody, but the rate of positivity can really differ. So in ocular MG, it varies between 30 to 70%, but in generalized is higher, 75 to 85%. And MuSK, as in adult MG, is rare, so less than 10%, so 1 to 5% based on most studies. So AChR is our predominant population. But with the antibody, I just want to specify the testing for the antibody is quite relevant, particularly for the pediatric, because the common standard, as you know, is the radioimmunoassay, but the specific cell based assay with clustering, which really is particularly relevant to the pediatric population from a study that we did in Oxford a few years ago, that our patients who were seronegative and found to be cluster antibody positive, a large proportion of them were young children with ocular and prepubertal MG. So in the patients you suspect MG, ocular MG or generalized MG, pediatric, if they're seronegative, test for the live cell-based cluster assay. That's very important.
Well, that brings up a very good question. So in the UK, is that a commercially available? It's hard to get in the United States.
Very good point. It isn't commercially available. We just actually have only one lab in Oxford who does, which does the assay for the entire country. Yeah.
Oh,
So
wow.
that is a challenge, yeah, to access.
And so I'm curious going along with the diagnostic approach. So in adults, if the antibodies are negative, then we reflex to repetitive nerve stimulation testing, single fiber EMG. What do you all do to confirm a diagnosis in a child?
Yeah, so similar process. Obviously, first and foremost is going back to the history and to make sure, you've got a clear history of, acquired new onset symptoms. But antibody negative, we would do neurophysiology. But again, that is a challenge in children. So rates of ocular MG is much higher. Rapid nerve stimulation being positive in ocular MG is, 30 to 50%. Single fiber, yes, higher rates, but the challenge with single fiber is the specificity is less, and particularly in pediatric that's really relevant because our patients with mitochondrial myopathies also come with ptosis, eye movement abnormality, and they might have a positive single fiber EMG when it's not really ocular MG. So I think that's important to consider, and that will be sort of the diagnostic process. But if a patient has a clear history and clinical features such as MG, it's really, or myasthenia, not MG. It's important to consider congenital myasthenic syndrome in pediatric population and obviously even in the adults as well. And there are some really useful differentiating clues which can help differentiate between them. So, for example, CMS tends to be early onset, before the age of 3 years. A family history of consanguinity can be a clue. The other is CMS tends to have symmetrical ptosis compared to the asymmetry that you see in acquired myasthenia. CMS patients really don't have diplopia, but that's a common feature in ocular MG in S-ways that can be. And again, the multi-system involvement, CMS patients can have cognitive, arthrogryposis, other system. You don't see that in MG, so that can be differentiating feature. But I usually recommend if you've got seronegative MG, you should check the CMS panel before you put patients on long-term immunosuppression.
Right, that's extremely helpful point. I think even on the adult side, sometimes we see these long-standing patients that these patients with a long-standing, symptomatology and they have not responded well to immunosuppressant therapy. And that sort of encourages us to remember to send the CMS panel even in adults occasionally. And you can pick it up that way, especially if there's a family history. So yeah, no, that's a really, really important point. And so now I'd like to pivot a little bit to talk about the therapeutic approach. So, as you know, on the adult side, for generalized myasthenia gravis specifically, there's just been a complete therapeutic explosion. We've gone from just acetylcholinesterase inhibitors as well as corticosteroids, nonsteroidal immunosuppressant therapies as the backbone of what we do, of course, with IVIG and plasma exchange for rescue treatments for crisis and exacerbations, to now ushering in this whole new chapter, right? With these newer, more targeted therapeutics, the complement inhibitors, the neonatal FC receptor antagonist, and then emerging therapies, including B and T cell targeted therapies. Cladribine is an example that targets both B and T cells that's going into a phase 3 trial and is an oral option. And so I'm just curious with this really incredible next chapter in MG therapeutics, how much of that is translating to our pediatric population?
You, I think I would start by saying it's really exciting to see that in the adult population as a first step because the underlying pathophysiology mechanism is same in pediatric and adult MG. So it hasn't really translated to pediatrics yet, primarily because most of the clinical trials are still in progress. Except yesterday, FDA did approve nipocalimab. Okay. So I think we are I think we will see over the next few years a change in paradigm on the pediatric side as well with these newer treatments coming and as to how we treat our patients. And that is actually quite relevant to our pediatric population, particularly the side effects of long term steroids can be extremely challenging to manage in young people, with the side effects, which affects compliance and, how we get their MG into remission. And also the time it takes to get them into symptom control, sometimes in the very crucial years of education and life. So I think these newer treatments really will help curtail that down to a shorter so we can get our patients better quicker and maintain them on these innovative treatments which work more effectively with slightly different side effect profiles that will help pediatric patients as well. But we need the evidence so far, both safety and efficacy.
So if we can kind of drill down on how you practice right now in 2025. And so you mentioned that there's a pretty high prevalence of ocular MG and seronegative in general in our pediatric population. So can you speak to what your treatment approach is first for the ocular MG patients, and then maybe speak to how you approach generalized myasthenia in our pediatric population?
So ocular MG, we start with acetylcholine receptor inhibitors like pyridostigmine, and I would say only in my experience, maybe about 20 to 30% might respond to pyridostigmine per se, but most patients do need immunosuppressions to get their myasthenia into remission. Steroids, prednisolone remains our first line immunosuppression, even in the pediatric age group. And then, depending on response to steroids, whether they remain steroid dependent or steroid unresponsive, we would go to second line steroid sparing, which tends to be azathioprine or mycophenolate mofetil. With generalized MG, it's similar to we start with acetylcholine receptor inhibitors, but actually with immunosuppression at onset because we know it's unlikely a pyridostigmine will get them into a disease control, and steroids, prednisolone is the first line treatment. Depending on the severity of a patient's symptoms, they might be topped up initially with IVIG or plasma exchange to get symptoms under control while the steroids start to work because we know steroids don't work immediately. There is a lag in the steroids starting to have an effect. So that's where we tend to be, I think, important to highlight with acetylcholine receptor antibody positive, particularly post-pubertal or peripubertal children, we would consider thymectomy as part of the treatment regimen, even in generalized MG early on in the disease.
Yes, that's extremely important point that we haven't made up until now. And so I admittedly have not been taking care of a lot of pediatric MG for quite a number of years, but when I did for the refractory patients, some of them required IVIG more chronically. Those who had either really significant corticosteroid side effects or those who just had refractory disease. So is that still in practice or?
About 20% of our patients still have refractory MG on the current treatments, and they need regular IVIG or sometimes even plasma exchange to get their disease under control because they haven't responded to the current treatments. We haven't mentioned rituximab, that's being used more and more, but the efficacy probably is much better for musk myasthenia than acetylcholine receptor myasthenia and seronegative, but something to consider there. So yes, we do, but I think what would be quite useful is, like we say, those 20% who are refractory is where the newer treatments, which are currently in clinical trial, will really be of benefit for them, hopefully.
Right, and I think we just mentioned a little bit ago that nipocalimab was just FDA approved for pediatric MG, I think 12 years and up,
12
do you
years.
recall? Okay. And then are there any of the other newer therapeutics currently approved yet for pediatric MG?
So, eculizumab is the other one that is approved for pediatric MG, and it has been approved for a few years and is used. Again, as we know, there's global differences in how drugs are available, but it has been approved and is available in several countries for refractory MG.
And then are you aware of other newer therapeutics that are in clinical trials looking at the pediatric population specifically?
Yeah, so we do have the FcRn inhibitors. So there's two FcRn inhibitors which are currently in clinical trials, and I think complement inhibitors also. There are clinical trials going to come in uh, uh, over the next couple of years. So similar to, I think, the same therapeutic treatments which are currently unapproved, they're coming slowly into the pediatric population, which is really exciting and really good because in the past we based all our treatments based on adult patients, adult studies. We never had any pediatric studies. So actually investing in pediatric studies is really good because the newer treatments, that's both for safety, tolerability, and efficacy, which is really, yeah, exciting era.
That's great. And I'm sure on the pediatric side, just like on the adult side, there are always some barriers to treating these patients, be it insurance status or, their geographical location and so on. Can you just speak to that concern with the specific barriers to treatment in your experience?
Yeah, I think one of the before barriers to treatment, I think the important thing is delayed diagnosis is very common in our patients because myasthenia gravis, it's rare in childhood compared to adults, extremely rare. So our patients having a long diagnostic journey is not uncommon. So first and foremost is that delayed diagnosis, and then the treatment. So access to treatment depends on approvals in different countries on how the drugs are approved and what particular criteria for approval is. For example, do you need to fail two steroid sparing agents before you have rituximab or regular IVIG? So I think that can be a barrier for accessing treatments when clearly you can see a drug number three would actually work much better much earlier on in the treatment um, flow sheet if the approvals were allowed. I think that is improving because the disease burden and the impact of myasthenia gravis is being understood better, and because of that, realizing that actually early treatment, getting disease under control early, has cost implications, which will help even if the drug is expensive, but actually in the long term, it is beneficial from a cost point of view, and obviously for the patient and the family as a quality of life.
Oh, that's so exciting. Yes, I agree with you completely. Our understanding of the burden of disease has come so far, and so we're really focusing on quality of life and how quickly these therapeutics will work and how we can lessen side effects and all those great things. So thank you for that. And so for our learners today, if you had just a few take-home points or highlights you'd like to emphasize, if you wouldn't mind sharing those.
So first and foremost, I think I would always say is go back to the history and make sure you've got what looks like myasthenic syndrome. Is it congenital or is it acquired? I think that's the first most. Get the diagnostic right. Um, Remember that your tests are not without. You don't have 100% positive tests. So a negative antibody or a negative neurophysiology does not rule out myasthenia, but equally you can get false positives. So be cautious of that. Make sure you do the appropriate assessments before you start treatments. You've got monitoring, really important to see response to treatment. um, and I think the other thing I find quite important is to realize myasthenia, at least currently with the current treatment, it takes time to get better. It doesn't get better in a couple of days, so patience is really important. Having that discussion with the patient and the family to say this is going to take some time, and also as the clinician you need to be patient. So I think that's important, not making too many drug changes too quickly because you want a quick response. And what I find, what is really important, I think, what is under recognized, the psychological impact. So, you know, important to have a psychologist. We more and more have them part of our clinics because actually it really, it has a huge impact on these children and young people, their myasthenia, and it is not really picked up till they improve. And then I've had patients, develop like functional symptoms because of the it's not being picked up early, the next psychological impact. So I think that's important to just consider.
Yes, thank you so much for that. And I just want to thank you, Dr. Ramdas, for being with us today for this video podcast called Understanding Generalized Myasthenia Gravis. Would really like to encourage all of our listeners to view the other video podcasts in the series and download the clinician and patient resources on the program website. Thank you.
Thank you, Kelly. It's my pleasure to be here.